Interventions with a King. Discussion and commentary based on articles from JACC, Cardiovascular Interventions.
I'm Spencer King. I'm editor of JACC Interventions, and we have a fascinating paper to talk about here today. I'm visited by Dr. Young-Hoon Jeong. Welcome. Dr. Jeong is from Yongsan National University Hospital in Korea. They've done some great work on a very interesting topic. Everyone knows that clopidogrel in the usual dose, 75 milligrams, is the standard recommendation. We're also learning that some people are resistant to that. Some people continue to have high platelet reactivity. And the question is, how does that relate to various things, including the genomic makeup of the patient? And Dr. Jeong, you have investigated this question. Tell us about the trial that you did.
Yeah, we enrolled 126 patients after PCI. They were all treated high maintenance dose clopidogrel at least 1 month. Because early period after antiplatelet therapy, the response is varies pharmacokinetics and pharmacodynamics responses. So we checked the platelet reactivity and later the HP high clopidogrel at least 1 month high maintenance of the clopidogrel.
All right, now the high maintenance dose you used was 150 milligrams, I understand, instead of 75, to see if you could overcome this question of resistance or lack of efficacy.
Yeah, well, we used the high maintenance clopidogrel for high-risk patients, clopidogrel, AMI, and diabetes, and upper-level indications of DS.
And we know already that those patients have a greater degree of high reactivity platelets than patients who are more stable. Is that correct? Okay. Well, tell me, did this work? What did you find using this high maintenance dose?
Yeah, we find very interesting. We assessed the DNA genotyping for CYP2C19 and the ABCB1 and CYP3A5 STAT3 alleles. Carriers of CYP3A5 and ABCB1 polymorphisms did not show the increased platelet reactivity compared with non-carriers. However, carriers of CYP2C19 polymorphism showed increased platelet reactivity, the higher rate of HPPR compared with non-carriers.
So the CYP2C19 did have high reactivity, those patients. And you looked at homozygous and heterozygous patients.
Yeah.
What did you know?
Yeah, as the number of CYP2C19 carriers increased, the platelet reactivity and the rate of HPPR increased proportionally.
All right.
Yeah, in multivariate analysis, we found out that the coverage of CYP2C19 polymorphism was only significant predictor of HPPR. The odds ratio nearly 6.
Okay, now, so to cut to the chase on this, the double dose, I call it double dose, the 150 milligram, in these high-risk patients with this allele, did the 150 dose solve the problem?
Yeah, maybe. Wild type, non-carriers of CYP2C19, I think the high maintenance works, but carriers of CYP2C19 polymorphism, it does not work.
Okay, so the homozygous patients, you need
absolutely,
you need something more permanent.
Yeah, the HPPR rate is 50% for homozygote carriers.
So 50% of the homozygous patients had high platelet reactivity. In other words, clopidogrel did not work. Is that correct?
Absolutely.
Well, this is certainly dramatic and important information. It is interesting to try to apply that to other populations.
Yeah.
You've pointed out that East Asian populations may have higher platelet resistance than others, which is a curious thing since thrombosis is not such an issue, and that's yet to be worked out. New agents are coming along. I think we'll all have to take this data to heart, but the bottom line for me is that just a simple doubling of the dose in these high-risk resistant patients is not going to solve the problem.
Yeah.
Dr. Jeong, thank you so much for visiting with us on JAK Interventions today.
Thanks.
Appreciate it.
Yeah, I appreciate it.